So, a lot of people come into my office and they are considering pregnancy over the next couple of years and they want to know how can I be healthier? Or maybe they've already tried for pregnancy and they've struggled to become pregnant. Maybe they are not having regular cycles. Um, we talk a lot about PCOS, polycystic ovarian syndrome, as a lead cause of menstrual irregularity and difficulty getting pregnant. And really, polycystic ovarian syndrome is hormone dysfunction that is often very tightly connected with insulin and blood sugar metabolism, even though we've not really talked about it from that way. Sometimes it's talked about that, oh, you're at risk for diabetes. We'll want to watch blood sugars, but we haven't really looked at should we be doing a deeper dive into insulin resistance and treating that as a first line treatment for polycystic ovarian syndrome in order to help bring back regular menstrual cycles, to help somebody achieve and maintain a pregnancy, really looking at it from this fertility perspective. Now, interestingly, I have talked to some of the medical liaisons at Novo Nordisk, and I asked them, when are we going to study anti-obesity medication specifically for the treatment of polycystic ovarian syndrome? And there was a quiet pause because drug companies are not going to want to evaluate the effectiveness of these medications for polycystic ovarian syndrome because of the risk of pregnancy. So what does that mean? So if we put people on a GLP-1 medication that works on insulin resistance and helps with weight loss, they will often have a significant improvement in the ovarian dysfunction from the hormone imbalance, and that can lead to better menstrual cycles and a better ability to get pregnant for many women. It's not 100% for sure. But if we're using these medications to do that, there is a risk of those women getting pregnant. And from the drug company's perspective, they do not want those women to become pregnant because then they have to stop the medication. So there's kind of this perverse system where they have a medication that might be very effective that we don't use during pregnancy, and they don't want to take the risk of allowing women to get pregnant on the medication unintentionally in this group of women who've traditionally struggled with pregnancy. When I'm talking with women, I do want to know, are you planning a pregnancy? Kind of what is the timeline? What are your goals? Because that will really help to direct the conversation. We don't use our GLP-1 medications during pregnancy or breastfeeding, primarily out of caution. There have been some women who've gotten pregnant on these medications, and we are watching their pregnancies and we are watching those children as they grow up to see if there's any harm. And to my knowledge, there's currently no harm, but we are not actively trying to lose weight during pregnancy. So if someone is going to choose to become pregnant, we're going to plan to stop these medications as soon as we know they're pregnant, or ideally beforehand to prevent harm. But when I'm counseling women, I just want people to know, yeah, you're going to need to go off of these medications, and just to know that that's important for healthy pregnancy. And, we would have a plan probably to restart when breastfeeding is complete. So having that counseling in place and knowing that, yes, it is true that weight loss and it is true that improving insulin resistance will often improve menstrual function, will often improve your ability to get pregnant, but just to know we're going to have to stop that treatment during a planned pregnancy or a surprise pregnancy. We do have some medication like metformin that can safely be used during pregnancy. So sometimes we're starting women on that medication knowing that we can continue that use during pregnancy. Metformin is considered off-label for the treatment of gestational diabetes, so diabetes of pregnancy, but it can safely and effectively be used throughout pregnancy. And that might be something that is a part of a healthy treatment for somebody. If somebody has diabetes before pregnancy, they might continue on their metformin safely. But when we are treating the underlying insulin resistance, we are often downstream improving ovarian function, and that really helps to reset menstrual cycles and can improve fertility. That's not going to be a solution for every single human. It doesn't work in every single human who is desiring a pregnancy, but it is an important part of care and something that I think we will see evolve over time.